Surgery Department, SCB Medical College. He passed his MBBS in the year 1981, and MS in the year 1990, and MCH in the year 1996, both from SCB Medical College. Now, requesting Dr. K.M. Jha on dais, please. Dr. K.M. Jha is a professor and head of the Department of Neurosurgery Department at Indira Gandhi Institute of Medical College, Patna. Now, I would request our chairpersons to carry forward the technical session.
A very good afternoon to everybody. This is the 5th session of the discussion. There are 3 speakers in this session. The first speaker is Professor A.K. Mahapatra. He will be speaking on traumatic brain injury in a pediatric population. I think everybody know him. He is a very renowned professor from Odisha. The same institution where I graduated and post-graduated. He finished his education and went to Delhi and never come back to anywhere else, staying in Delhi always.
Good afternoon, chairpersons and friends. It is indeed a great pleasure to be here this afternoon to talk some experience of pediatric head injury. As we discussed in morning, the head injury is a real problem and it has already acquired an epidemic proportion in India. We are really struggling how to control and treat head injury. Way back in 1963, Robert McLaurin, the pediatric neurosurgeon from Boston, wrote, "Child is not a small adult," or "neonate is not a small child." So we have to understand the pathophysiology and management of pediatric head injury can be newborn, neonate, infant, toddler, and some child above 10 years. So the brain almost behaves normally as an adult brain up to 12 years of age. But if you look at the world literature, International Society of Pediatric Neurosurgery accepts 18 years of children. And when we look at the paper from Child Nervous System or Pediatric Neurosurgery or Journal of Neurosurgery Pediatrics, we accept almost up to 20 years. And new things have emerged now. Adolescence medicine, because people started thinking between 15 and 20, the pathophysiology, endocrinal disturbances, attitude, and all if you look at, there is adolescent medicine. But we are not talking about adolescent medicine. In 1994, Neurotrauma Subcommittee of India had a symposium on pediatric head injury at Cochin. I don't know Dr. Mahanti remembers or not. That time I sent a questionnaire to about 20 centers of India, and we found out pediatric head injury constitutes between 25 to 35% of head injury. But if you increase the age from 18 to 20 or 15 to 20, even today many pediatricians will say pediatric age group is up to 12 years. So we are not talking about those type of pediatrics. We are talking about 20 years or 18 years. It will be around 30%. So we are talking about India's population which is below 20 years is about around 30%. So it's a huge number of population, and if we extrapolate little over 2 million accidents per year and about 160,000 deaths in India every year, and 1/3 of them constitute a significant proportion. So we are talking about pediatric head injury, which is also a very important aspect of head injury management. If you look at the birth trauma, we all know, just last last Tuesday, I saw a child of birth injury to the brachial plexus. We have variety of injury which occurs to central nervous system and peripheral nervous system during birth. Of course, we have cephal hematoma, periosteal hematoma, fracture, depressed fracture during forceps delivery. We have also battered body syndrome. If you look at the story which was last for about 3 months at AIMS Trauma Center, the baby who stayed in hospital for 2 years was a 2-year-old baby with battered baby syndrome. So it is underreported in India because of our socio-cultural, but believe if you leave your child to a ayah or a nanny or a maid, he is going to be malhandled by the maid. So we have underreporting of the battered baby syndrome. If you look at the literature from India, in pediatric age group and elderly age group, fall is the most common, and more often in the cities it's from rooftop, and in the villages or urban and rural area it's from the trees. So if you look at the TBI, central TBI, European study under the European Union, they have found out even in adult population in Europe, the commonest cause of head injury is not road traffic accident. But when we analyze 25,000 of head injury, central TBI, which is going to be presented to the European Parliament on 7th of this month at 11 am, the Indian data showed even today for adult 65% head injury because of road traffic accident. But when we were resident about 35 years back or 40 years back, the road traffic accident was the common cause. So we still have a significant proportion of head injury occurring in the pediatric age group because of road traffic accident, because of motorcycle culture in India. Ever since the Hero Honda has become a part of Indian culture, every child get a gift in the birthday, a motorcycle. So it is understandable. So we are talking about most common causes fall, if you take something below 10 years of age. But some children also get injured during crossing the road or falling from the bicycle. So this can happen in the road also. So if you look at this slide in the right side, in Delhi in 2015 there are 1835 deaths out of around 15,000 accidents, and the motorbike constituted 50%. It's demoralizing, but the truth we have to accept. But if you take across India, in the morning I was showing you, in the epidemiology, about 28% die in Indian road by the motorbike accident every day. So we have to be very careful when we give a motorcycle to our teenage mad boy. Again, coming to the type of injury and pathology, we all believe extradural hematoma is rare. If you take below 10 years or below 8 years, that may be rare. But after 10 years of age, believe or not, it's as common as the adult. Again, we know that extradural hematoma is posterior fossa, due to some reason or other, is more common in pediatric age group. And there are several papers published in the world literature, ultra acute extradural hematoma, the posterior fossa, when the hematoma rapidly grow and kill a child maybe within few hours. So we have to understand posterior fossa extradural hematoma is common in children. It could be posterior fossa and supratentorial combined in about third of the cases of posterior fossa hematoma, because there is a transverse sinus injury in which hematoma will be partly below the occipital bone, below the turcula, and partly above the turcula. Another common cause of temporal lobe injury. A study in our post-concussion syndrome in children, we did a SPECT scan. In post-concussion, minor head injury in children, when you compare the adult and pediatric age group, most post-concussion syndrome in adult, the SPECT scan show more frontal perfusion defect in adults, and in pediatric age group, it was more temporal defect. So we believe temporal lobe is more vulnerable in pediatric age group than adults. And closed depressed fracture. All of us are very fond of closed depressed fracture, and in the literature there are variously named: ping pong fracture, closed depressed fracture, a smooth fracture, pond fracture, many things like that. There is always a controversy: what do you need to have treatment, operation, elevation for the depressed fracture or not? Still there are a lot of controversy, but there is probably consensus: if there is a depressed fracture, pressing of the motor strip and producing hemiparesis, then there may be a point to go ahead and elevate the depressed fracture, because you would not like to have our frontal lobe motor area compressed for a long time. It may come up with the brain pulsation, but it may not be ideal to wait for the depressed fracture, closed depressed fracture to come up by the natural process. Next is that in pediatric age group, many children do deteriorate with fits. You know that immediate post-injury fits are more common in pediatric age group because they do not stand hypoxia. Immediate following the concussion, there is slightly respiratory abnormality when the oxygenation may be optimal. It's suboptimal oxygenation of brain, thereby immediate post-injury fits are more common. But all the long-term post-traumatic epilepsy have not shown is there any relation between immediate seizure, post-operative period and long-term seizure. There is no direct correlation. One more point I want to emphasize in the pathophysiology, that a lot of people say all the decompressive craniotomy across the world talk about 20 magic figure of intracranial pressure. It is, I think, sad that people talk about 20 because we have no clue to know what is the intracranial pressure in children. There is one paper from Derek Bruce from Dallas, one of our friends, who was a pediatric neurosurgeon who dared to have intracranial monitoring below 6 months normal children and found is less than 5 millimeters of mercury. So if a child has a hematoma at 1 year of age and we are waiting for 20 millimeters of mercury to go up, you are damaging the developing brain. So we do not have normative intracranial pressure for age below 1 year, 1 to 5 years, 5 to 10 years. But I would believe, do not think 20 taken for the adult by the adult neurosurgeon is also extrapolated to the pediatric age group where pressure of 20 may be detrimental to the brain growth and neuronal survival. So one has to take very careful decision in individual case how much pressure in what age group is optimal. So there are another situation in head injury. If a minor head injury child is well and you think everything is okay, and with little hypoxia, little respiratory obstruction, minor fits, he may deteriorate. So observation becomes much more, one has to be very careful if a child is less than 3 or 4 years of age. Other problems are the physiology. They do not stand hypoxia or hypotension. By and large, we believe a isolated head injury will never produce hypotension in elderly or adult unless associated with spinal cord injury in cervical region. So if you are expecting that a head injury has produced shock in adult in absence of hemothorax or abdominal visceral injury or spinal cord cervical, it is not correct. An adult cannot bleed too much in intracranial cavity to go to shock. But this is not true for children. Children below 10 years of age can bleed enough under the scalp to go for hypotension. So one has to be very, very important to understand the pediatric physiology, pediatric blood pressure maintenance, pediatric cardiac cycle, narrow airway. I don't know how many understand that the trachea is incomplete, the tracheal ring is incomplete, and there is no muscle. So very, very, when somebody struggles stagger, more the struggle, trachea becomes more narrow. So they will go into respiratory arrest and stagger very fast. So if you have a child who has little noise in the respiration, it is one has to very carefully maintain the airway. Otherwise, a child may have normal brain, yet may have respiratory arrest. So that is also important. Another aspect of head injury management pediatric age group, they all push into the adult head injury cubicle. Even today at AIMS, we do not have a pediatric neurosurgery ICU or pediatric neurosurgical neonatal ICU, because again we are telling neonatal ICU is not pediatric ICU. That is why we have called NICO and PICO. PICO is in Indian term pediatric intensive care unit, NICO is neonatal intensive. These are the terms coined by the government of India. So neonatal intensive care is not same as pediatric intensive care. Pediatric intensive care is not same as adult. So we all dump them as a common kettle of fish or a package of bread. That's not true. ICV monitoring, very few paper. If you read at the Dirocos paper from Rome, he has tried to differentiate whether ICP or CPP. It is not yet settled. ICV monitoring is helpful for adult head injury management. Out of 2,000 papers published, maybe more than 2,000 papers published in the world literature, in 1958 when the Lundberg has described the ICV monitoring, we are still not sure IC monitoring does help or doesn't help. Why it is so? In all severe head injury, only 70% manifest intracranial pressure high. So 30% severe head injury may not even once manifest raised intracranial pressure. So severe head injury is not equivalent to raised pressure or clot. It may be a neuronal failure, neuronal dysfunction which makes the person unconscious. So it is not that somebody's coma means raised intracranial pressure, operation. So 30% severe head injury can have normal pressure. On the other hand, 30% of minor head injury can go to a state of raised intracranial pressure. So one has to understand ICP has its own limitation and no class 1 evidence is available in the literature whether ICP monitoring helps in the management and survival outcome of severe head injury. Second, to add to the complication, people talk about it is not ICP which is important, which is cerebral perfusion pressure is important. Here there is a difference between pediatric and adult. We think in adult population, 65 to 70 ml blood per 100 grams of brain tissue is good enough to maintain an optimal perfusion of the brain. So far, the pediatric pediatric age group is concerned below 10 years, we believe 50 to 60, around 10 to 15 ml less circulation to the 100 grams of brain is optimal for a pediatric age group. So when you talk about physiology, respiration, blood circulation, immaturity of the autoregulation, blood-brain barrier, they are not same as the adult. Up to 2 years of age, the blood-brain barrier in the child is not matured. So they behave erratically, not the scientific manner a adult behaves. So one has to be very careful extrapolating adult to the pediatric age group. So there is significant controversy, ICP, CPP or venous jugular vein oxygen saturation. All of things we have tried at AIMS, we are not sure. Then we shifted to transcranial Doppler, then we shifted to microdialysis. All has been developed last 30 years, has not added to survival benefit in last 20 years. So whether you do IC monitoring, CPP monitoring, jugular vein saturation, microdialysis, transcranial Doppler, it has not shown that there is a survival benefit in last 20 years. So one has to be very careful. We have done a lot of study. It is SP Agral's thesis of IC monitoring between 79 and 80. From that time till 90, we have done several theses of postgraduate in IC monitoring, but we regularly did not monitor the ICP in pediatric age group. So after the trauma center came in 2007, all of our severe head injury, we try to do IC monitoring. So that is one of the criteria we have followed, even though we know IC monitoring may not be having a class 1 evidence for ultimate outcome. So that is very, very important to understand. This is one of the study when we analyze, and this is published in Brain Injury. This is 264 cases of pediatric. Here I want to highlight severe head injury 45%, 47%. When you go to the European study of head injury or head injury across the world, it is about 10 to 15 cases percent are severe head injury, rest are mild or moderate. But because we are tertiary center, we have a level 1 trauma center, we have tremendous need to have admission to the severe head injury. In fact, we get around 30,000 trauma patients in our trauma center every year, and we operate somewhere about 1,000 trauma cases of head injury and 500 cases of spinal injury, nerve injury, peripheral nerve injury, cranioplasty, post-traumatic hydrosol, etc. So we operate somewhere 1,600 cases of head injury and spinal cord injury, peripheral nerve injury. So here I am trying to show that 47% of pediatric injury are severe. So it is not as per the data available from the world, it's higher. If you look at the operative intervention, because you have large number of severe head injury, operative intervention was 56%, which is a very high percentage of operation. And 4 parameters were factors for significant. One parameter was whether there is coagulation abnormality or not. Second parameter, which was very significant for the outcome, was the hypotension or not. So overall mortality was 18%. This is also, I sometimes believe, bias study, because a person who comes with 1 hour of injury, he gets intubated and ventilated. So if you take 6 hours of head injury, unconscious, a severe head injury, maybe the person followed for 6 hours, many of them become conscious. But can you take the responsibility to see that waiting for 6 hours somebody is not deteriorate. So there is a clause that how many of these people, those who intubated at 1 year or 1.5 years of injury, are really severe or moderate or minor. We don't know. It is likely minor, it could be moderate head injury, who was otherwise could have improved in 6 hours. So that's the problem. So there is an inherited problem that if you ventilate every severe head injury, we presume they are all severe. They may not be severe always. So there is this is the p-value of this 200. The first thing is that severe or mild, this is a mortality. We all understand severe head injury, high mortality, so mild to moderate or less moderate. So there is not much difference. But what was very important here, coagulation disorder in child or no coagulation. Routinely, neurosurgeons do not do coagulopathies in head injury. Believe or not, a significant number of patients who have coagulation disorder, which can further jeopardize the intracranial circulation to the brain. So if you have a hypercoagulability of the brain, of blood, it is going to affect microcirculation of the brain, thereby reducing the cerebral oxygen consumption. So one has to understand that. Second is whether the patient develop infection, no infection. What infection? It could be chest infection. We all know the fever, pyrexia above 100 degrees Fahrenheit after 24 hours, or a glucose of 200 at admission. These are all independent monovariate analysis. These are independent parameter for outcome. So we have found out infection or no, it could be lung infection, could be septicemia. That is the reason people are talking overall coma scale, coma scoring or stress scoring in ISS scoring in head injury. So this is another study, decompressive craniotomy children. Just we are hearing DECRA trial. In last 10 years or so, there are 6 trials all over the world. One is ADAPT study for pediatrics from US. There is a decompressive craniotomy study which is published in the New England Journal of Medicine. There is another study called Rescue ICP by Peter Andrew. There is another study called Eurothumb study. Then TBI, Central TBI study. So there are at least about 10 multicentric, multinational decompressive craniotomy. But the gist, if you would have understood what Dr. Peter really said, it has not really increased the outcome survival in long term. What it has done, it has converted some vegetative state to severely disabled. So if you analyze after 6 months, 1 year and 2 years, your good recovery rate has not increased. Some people, those who have died, has become vegetative, or some people who have remained vegetative have become severely disabled. So it has not given a good outcome in anywhere in the world, so far the data analysis is concerned. So this is the study of a pediatric age group 2008 to 14, published recently in one of the journal, I think Child Nervous System. So these are the factors which are details of injury, age profile, CT finding, surgical procedure outcome, usual way of doing it. So this is the, you see, this is what happened. Below 3 years, how many are there? There are a lot of people are below 3 years. Because in this study, we have taken children below 3 years. And see the number, because this is very, very selective, sensitive, pediatric age group who are vulnerable to brain damage following head injury. So the Glasgow Coma Scale is 8 or less, between 8 and 12, because adult Glasgow Coma Scale will not be applicable to this pediatric age group. So now what we have, acute subdural that occurs in pediatric age group. Extradurals are relatively rare. You can person can have contusion and DIA. So these are the type of pathology where the child can have. And when you did a decompression, there is a permutation combination. There is a primary decompression. One can ask what is primary decompressive craniotomy. Here you don't do the IC monitoring. You take a patient to the operation theatre from the CT scan room because a huge, significant midline shift or a large intracranial hematoma, you feel, or the surgeon feel that he can decompress and give a survival benefit without undertaking the child IC monitoring. The secondary DC is if a hematoma is there or there is a diffuse axonal injury, you put a IC monitoring. If the ICP remains high, you go for secondary craniotomy after observing maybe 24 hours, 18 hours, 24 hours or 36 hours of IC monitoring. So then what do? We can have a bilateral decompressive craniotomy. You can have a unilateral decompressive craniotomy. We have sometimes decompressive craniotomy posterior fossa because the cerebellum is also swollen. So there could be decompressive supratentorial and infratentorial. So the unilateral frontotemporoparatal craniotomy, where the optimal length and breadth should be 15 by 12 centimeters, so that if you do a small craniectomy, it will be inadequate to prevent the intracranial pressure. So your craniectomy should be adequate, so that is the optimal size, 15 by 12 centimeter. It could be bifrontal if there is bifrontal contusion, it could be biparietal, it could be also posterior fossa, depending on where do you think there is maximum pressure in the brain. So outcome, we just say that overall survival is 56% in pediatric age group as compared to, I think these are compared to also the adult population. Now I have been told that mortality is come down to 24%, 25%, but I am not sure. Then ventilator associated pneumonia, 35%. That is one of the most common killer both in adult and pediatric. If a child, we always think ventilation is panacea or treatment for everything. It's not true. Unnecessarily ventilating a patient for a longer period of time and creating the pneumonia and respiratory problem is not good. It occurs about 35% of cases and it is add to the risk. So every infection in the body in a head injury patient, whether septicemia, chest infection, thrombophlebitis, urinary tract infection, they will add to the problem and cause problem. And there could be sometime subdural hygroma, post-traumatic hydrocephalus and tracheostomy required for the long-term ventilation purpose. So these are the things, ICP value and outcome. Here I was telling, in this study also I criticized my juniors, telling that why 20, why 15? 3 years old baby, 15 is very high. 15 intracranial pressure is very high, because some people in world take normal between 15 and 20 normal pressure for adult. So if we would have taken below 10 or 10 or below, the things would have been different. So the analysis depends what your standard of parameter you are keeping. If I would have taken into below 10, 10 to 15, above 15, the analysis would have been different. But nevertheless, it's published, so nothing wrong. So pediatric head injury in school children, what can you do? How can I prevent? When I go to school to talk or give a talk for prevention of head injury children, they laugh, because we have not inculcated. I was telling some of our friends from Jordan, Amen, they are talking, showing the brain model to 3 years, 4-year child. They are giving the helmet, they are showing the color helmet to children. So they inculcate the interest in the children from very small child below 3, 4, 5 years of age. So by the time they come to school, they know the devastating effect of the head injury, whether minor or severe, the value of the helmet, how the helmet is protective in preventing severe head injury. We have failed totally in giving the school children the real perspective and future of pediatric head injury. Also, we have failed in rehabilitation. We neither have physical rehabilitation, systematic rehabilitation. Many times we in neurotrauma conference, we get our friend from US and abroad telling rehabilitation can start as early as 3 days. Respiratory rehabilitation, physiotherapy for the limb, and when the patient comes out from coma, he will require mental, social, physical and occupational rehabilitation. We have zero rehabilitation in India. AIMS is trying to have a 500-bedded rehabilitation center in trauma center, just back of the trauma center, but it may take 10 years, as you know. So it is very, very important to understand. And second thing, minor head injury. We did a lot of study in minor head injury, studying their intracranial pressure, pulse oximetry. We also saw transcranial Doppler, P53 wave, visual evoked potential, and then SPECT scan. And we found the children which you would have thought behaving abnormally, they have abnormal cerebral blood flow. So the parents and teacher will think the child is malingering, he's probably taken advantage of his head injury, but it's not true. You have to understand post-concussion syndrome is a terrible condition. It affects socially, physically, mentally and performance-wise. That's what happened in Vietnam War. Minor head injury soldier when went to US back from Vietnam, 50% of them were psychosomatically, behaviorally abnormal to lose their job. So it is a big concern that minor head injury, how minor is the minor head injury? Would you like to have minor? Do I like to have minor? No, I won't like to have minor head injury, because my personality will change, my psychosocial change will change, my behavior and memory will change. So this happens to school children, which you do not understand as a neurosurgeon. Unless you understand even a minor head injury is bad enough to damage brain in a child, we will not be doing justice to our children. So that's very, very important for us to recognize. I think the surgery is not very important. Conduct awareness program. All of us have tremendous responsibility. If we want, I don't know how many of you read the Think Fast Society. There is a Think Fast Society started in Canada first in 1960s, and US had a Think Fast Society. They had a caption, Save Our Teens. American caption, Save Our Teens, in 2004. What they are talking about? They are talking about the young people between 10 and 20 dying of accident. India, you don't talk about that. Can you have a slogan, Save Our Teen from motorcycle accident, prevent the pediatric head injury, go to the school, give the public awareness program, encourage people that they follow the red light, do not drive drinking or that without helmet. All these things can have a better outcome for the future unless we do the preventive aspect. No matter how many neurosurgeons we produce next 30 years, head injury is not going to come down in India, nor it will be in future we will be able to manage all head injury in India. So we have to educate the children, we have to educate the public, we have the helmet, seat belt, red light, teaching traffic rules. All these things matter in a long run. There are several publications. Out of 200 publications I have done in head injury, maybe 50% or 30% of pediatric. There is no point of showing all this. So let us conclude that it's a very important aspect. We care our elder. We are talking about geriatric medicine, geriatric center, geriatric planning. The government of India is going to have a geriatric cell in the ministry. But what is you saving the pediatric people? If we cannot look at our children, we talk about, I don't mind to talk about the geriatric because many of us have become elderly, above 65 years of age. Both the age above 65 or 70 and below 10 years or below 5 years, they are equally important for all the country. So if you want to have a peaceful country and a good survival for children, we have to see that our children don't die of head injury. Thank you very much.
Professor Mahapatra has a long interest in head injury and pediatric neurosurgery. So that makes him authority in this pediatric head injury. And you have listened an authoritative lecture on this. And he has tried to deal all aspects of pediatric head injury. Still, if someone has got any doubt, anything to clarify with Professor Mahapatra, he is welcome. Professor Tripathi.
Sir, with your vast experience, I just want your experience with two types of head injury in children. One is sports injury. We just recently had an under-17 World Cup in Calcutta, and just remembering that. And number two is we've seen some maybe 3 years or older plus minus with traumatic internal capsule infarcts with hemiplegia and aphasia depending on which side is affected. And eventually they all get better. So with these two, with your experience, please.
Actually, when the CT scan came in 78 in Delhi, I had collected the basal ganglia hematoma those days in between 80 and 84, and we found...
Say infarcts, not hematoma.
Coming to that. And then I found out, long back, Erwin Cooper had written the anterocordial obstruction following head injury and infarct in the basal ganglia. And then you go back to 1940s, Kuruhil, the neuropathologist, has written the basal ganglia are very vulnerable for the hypoxic injury, selective because of these arteries are end arteries and there is no cross circulation. So basal ganglia hematoma, if you read my head injury book, there is a chapter in basal ganglia. So we saw a lot of, there is no specific unless you read the Dr. Dharkar paper. Dharkar has written 10 or 12 cases of unilateral versus bilateral basal ganglia infarct following pediatric head injury. So it is a known fact that basal ganglia can get less blood circulation because of anterocordial artery problem, which was highlighted in 1960s by Erwin Cooper. Coming to that 3 years, 4 years. See, you understand, today we are talking about neuronal reorganization, neuronal reconnectivity, and also there is a doctor called Atul Sur from MIT. He has been trying to have, if you damage the visual cortex in a rat, after some time you see the auditory cortex take over the visual cortex. So there is cross connectivity of the brain, which people are not thinking. There are two things happens. One is neuronal plasticity, when one part of the brain damaged, another part get activated. I don't know how. I think Peter really must be knowing. There's a very beautiful case. A person had head injury. He remained in coma. He was a very ordinary man before accident. When he recovered, he became genius, and he was become brilliant student. So, what is the connection between a head injury and somebody become brilliant after? This was a story in US. It got a best attention of the public in the media. The question is that we all know after head injury, some part of the brain gets less function, and in a child with a plasticity, some part may be hyperactivity. So the question is that many pathophysiological process following head injury, you know what are the sleep disorders? We have written 2 papers on sleep disorder. Do you know what is the sleep disturbance? Unless you go all minor head injury, there are sleep rhythm, what happens to sleep rhythm, what do the, so many things we don't understand. And one of them is here, the neuronal reorganization, neuronal recircuiting following head injury. And it is a reality in pediatric injury. Thank you. Any other question, please? Sports injury. It's a very common which is underreported. If you look across the world, you know at least 1 dozen of people dying of cricket. And 2 of them, one from Australia, one from India, Raman Lama, and many others. And these are only celebrities. But the cricket is not only played by celebrities. These are the tip of the iceberg. Cricket is a religion in India. Every child after 5 years wants to be Sachin Tendulkar. So play with a rubber bat, then a bat, then a wooden board. So they get hurt either as a visitor or an onlooker or a player. It's bat injury, ball injury, and wicket injury. So there are various types of sports injury. You have got punch drunk, you have boxing, you have wrestling, you have football injury, you have many things. So the question is that you know that Muhammad Ali had got early dementia because of multiple boxing injury he had. So the question is that sports injury itself is a subject. And now people are doing specialization of sports injury. When any team go for Olympic, they are accompanied by 2 or 3 person which is designated doctors on sports medicine. So it is, we have a sports medicine center in Safdarjung Hospital. So it has a subject, a topic of its own. We are not going to discuss. It's a very, very important topic. Thank you very much.
Thank you, sir. Just a last comment. So, thank you, sir, for your excellent and authoritative talk on pediatric head injury. Just one comment I want to add. And the thing is,
you have to answer.
No, sir. No answer. Sir, the thing is that we are getting cases branded as head injury without a general examination. So this is my request to all youngsters that whenever they get a pediatric head injury, they must also look for other injuries. Because recently I got a case of multiple injury, fall from a height, a child, and the radiologist and the casualty medical officer told the scan is normal, child is normal, you can take home. But later on, it was found that he has got a hepatic injury and a very low blood pressure. And he has to be managed, and later on, after a few days, he became all right, of course. So that's my suggestion, that you must also look for other injuries that contributes to the outcome of injury, general injury. That's one point. Second is, the pediatrician always tell that a blood pressure of 90/60 is okay for a child. So I don't agree with this, that sometimes the measurement of blood pressure is faulty. They do not use a proper cuff to measure the blood pressure. Maybe monitor sometimes might not be functioning all right. So all these things has to be taken into account for the complete outcome of the child. Thank you.
So after this, we will go to the second paper. That's on neuro rehabilitation in head injury. It will be by Dr. Peter. Dr. Peter.
Thank you to Professor Riley, the Australasian Society of Neurotrauma, and the local organising committee for the invitation to discuss rehabilitation for vegetative state and severe disability after severe traumatic brain injury and the journey that occurs. The title suggests that everyone will become independent, but I'm going to rephrase that and say that there's a recovery plateau. I don't have any breakthroughs to achieve independence in all, because when you've had a severe traumatic brain injury. There are some very good recoveries. There was mention of that extraordinary case where someone became brilliant in another area, but I think that's one in a many billion of brain injuries rather than the common brain injury that we see. Patients and families find themselves unexpectedly and reluctantly as participants in catastrophic and severe brain injury. The Glasgow Outcome Scale was initially a 5-point scale and then expanded to become 8 categories. It, however, has poor discrimination and a very low ceiling effect when describing the good recovery categories. And one of the things, although it calls itself an outcome scale, it really depends on when you actually do the scale, because the outcome is, 5-10 years later, and really it's a status of disability, because some of the categories are really phases of the recovery. In Australia, the rehabilitation units use the functional independence measure, which is a standardised collection for function at admission to rehabilitation and on discharge of rehabilitation. And it looks at mobility, transfers, toileting, dressing, communication, problem solving, memory, and that's the score that we use. And I'll be discussing some results from that. When the journey starts, patients are encountered with an overwhelming experience. They've got a steep learning curve, which may well become lifelong. They're not helped by society myths and fictional representations of the situation. They find themselves in real life roles, but this cartoon here contrasts the stark difference between what happens after coma when it's scripted in a TV soap opera, programs such as Days of Our Lives and General Hospital. And in the TV you can see the miracle recovery from a coma, while back in real life the patient's still in the coma on the bed. The outcomes of coma, surprisingly, have actually been systematically and scientifically studied for the US daytime television dramas and reported in the BMJ. And what they found was that the mortality in the TV dramas was 1,000% less than the reality data, which was, and the recovery to normal was 90% in the TV dramas, whereas in real life data for people that had been in coma for prolonged periods of times, it was 1% and 7%. Now, this is some data from the Victorian State Trauma Registry, which describes the outcomes at 6 months after moderate to severe traumatic brain injury from that state. And at 6 months, vegetative state accounted for 2% in both the severe and moderate TBI groups, while the proportion with severe disability at 6 months was nearly 30% in the severe TBI group and over 25% after moderate TBI. Good recovery had occurred at 6 months in 27% of the moderate TBI cases and in 17% of the severe TBI cases. By 6 months, death had occurred in 5% of moderate TBI and just under 5% in severe TBI. The Glasgow group researched disability outcomes at 12 months after hospitalisation with head injury, such as after hypoxic brain injury. The person is unlikely to recover if they've been in the vegetative state for 3 months or longer. The term vegetative state is difficult to explain, and it has unacceptable and negative connotations. And there have been preferred newer terms, such as the unresponsive wakefulness syndrome, post-coma unresponsiveness, disorders of consciousness, suggested and proposed, but I think it won't be accepted until we see a change in the terminology of the Glasgow Outcomes Scale, and maybe that's something that might be need to happen. The minimal conscious state, or the minimal responsive state, can occur from coma or from the vegetative state, or sometimes people go from vegetative state to just severe disability directly without going through the minimal conscious state. But in this state there's minimal but definite behavioural evidence of self and environmental awareness, and the ability to follow command or gesture in some way for yes or no, either verbally or by some motor response. And it doesn't matter whether the yes-no response is always reliable. It's just a matter of the fact that the person appears to be saying yes or no. And there are movements or behaviours that occur in relation to some stimulus, and they're not reflexive. And one of the things that is the most reliable indicator of recovery to minimal conscious state is the return of ocular or eye fixation and visual tracking. But you need to be aware, or we should be aware, that there are exceptions to this. And one of the important aspects of understanding the vegetative state is the high misdiagnosis rate. And the article by Andrews was reported in the BMJ, where they found a 43% error rate in patients diagnosed as vegetative state. They had 40 cases referred to the Hospital of Neurodisability in London, and 17 of the cases were actually misdiagnosed as being in vegetative state. 7 of the cases that apparently been had been in this condition for a year, and 3 cases had been in this condition for over 4 years. But accurate diagnosis requires skilled multidisciplinary team experience in evaluating low-functioning patients with complex disabilities. And these results have been replicated in other studies, and the error rate for vegetative state is in the order of 40%. So while eye fixation and visual tracking are good signs of recovery and progression from vegetative state to minimal conscious state, the absence of these eye signs are not reliable, and it's important that the Andrews study found that most of the patients who were actually misdiagnosed had severe visual impairment, so that they couldn't do eye tracking, and it was important to find some other way to establish that they were aware and can respond. So when there's visual field impairment or visual acuity impairment or some cranial nerve injury affecting eye movements, you need to think very deeply about the examination techniques that you're going to use. And recognition of awareness and a method to establish communication in these patients is essential for their quality of life, and also for avoiding inappropriate treatment decisions. The outcomes from the International Data Bank reported 50% mortality as the one-year outcome in survivors with vegetative state at 1 month and 3 months. 10% of these patients with vegetative state at 1 month became independent at 1 year, while 11% remained vegetative and 26% were severely disabled at 12 months. None of the vegetative state survivors at 3 months recovered independence, but 31% remained vegetative, while 20% entered into the severely disabled group. While there is some guides to prognosis, it's often difficult to actually be categorical or super confident about any particular person if they've survived several weeks after traumatic brain injury. It's certain that they will have some significant level of disability, and a long period of rehabilitation can be reasonably expected. Scales are used to assess disorders of consciousness, and these are the scales that are used. My own experience has been with the Western Neurosensory Stimulation Profile and the Wessex Head Injury Matrix. The Coma Recovery Scale is used in North America, and the SMART Scale is used in the UK. The SMART Scale is proprietary, so you have to purchase it. Both of these scales have good evidence of reliability and validity. But the the Wessex scale is in the public domain, and it's particularly useful because both the nurses and the family can use the scale, as well as the members of the multidisciplinary team, and you can record behaviours during the person's progress of recovery of awareness, responsiveness and communication. The bedside assessment for disorders of consciousness takes extended and repeated observation and examination time. One really needs to be prepared to wait several minutes, 10 to 15 minutes even, for a delayed response. So if you're expecting an immediate response, you may well miss it. Eye fixation and eye tracking is what we look for, but again, you need to be aware that that may not be able to occur because of other injuries to the visual system. And family and nurses are key and usually very reliable, and that they recognise recovery of consciousness because of their long patient exposures and observation times. Recognising the recovery of sensory functions, that language, cognition, motor deficits, and those abilities is important for rehabilitation interventions and for treatment decisions. There are no standard of examination or response. Okay. There's no test. There's no investigation. And it's particularly important to establish that there has to be consistency of responses versus the responses being random. It is obvious that care for patients in vegetative state, minimal conscious state and severe disability require nutrition, special care, skin care, bowel bladder management, airway management, management of spasticity and special equipment, and developing and avoiding complications and managing them when they occur. But where patients with these states get cared for really can determine their outcomes. Rehabilitation for this group can be limited. In the United States, some of the hospitals enrolled in the TBI model systems admit non-responding patients with disorders of consciousness. In Australia, patients usually have to recover from vegetative state and disorders of consciousness to access rehabilitation care and participate in rehabilitation, so they don't come to rehabilitation. And these are some of the additional problems that we see in these severely disabled patients. Problems with contractures, autonomic dysfunction, seizures, heterotopic ossification and thromboembolism. The US model, TBI model systems and the National Institute for Disability Research and Rehabilitation have looked at the long-term outcome for some of these patients, and this particular study looked at 400 patients admitted to their units with coma, vegetative state and minimal conscious state for 11 years up to 2009. And they found that nearly 70% regained consciousness, close to a quarter emerged from post-traumatic amnesia, and their functional independence measure scores went from the lowest of 18 to 43 upon discharge. which is still very dependent, and 21% achieved a capacity for living without in-house supervision, and at their 2- and 5-year follow-ups there were significant improvements in their FIM scores and they were needing less supervision. This was an arm of that study, and they compared the eventual outcomes of two groups, one where they had recovery of consciousness during rehabilitation, and the other group, who they called the late recovery group, where their recovery of consciousness occurred after discharge from the rehab. And they looked at the functional independence in the activities of daily living and mobility in the two groups. And this was the early recovery group, and the FIM score is, the lowest score is 1 and the highest score is 7. So 1 is completely dependent and 7 is fully independent with or without aids. And they found that in the early recovery group, there was recovery, 7% recovered on bathing and up to 21% recovered transfers at rehabilitation discharge. And by 5 years, that's the top line there was 56% were independent on problem solving and 85% were independent on ambulation or with a wheelchair. And on the group that didn't recover consciousness during inpatient rehab, they were still followed up, and at 5 years there was 19% fully independent on the memory scale and 36% independent on transfers. There was a difference between the two groups though, because the ones that were had early recovery of consciousness actually stayed in rehabilitation and had much longer intensity and prolonged rehabilitation compared to those that were just sent elsewhere and then followed up. Now, late recovery can occur beyond 1 and 2 years, particularly with traumatic brain injury, but it is uncommon, but it can occur. And of course, we always see these delayed recoveries 10 and 15 years later. So, and there's a push to use novel therapies for this particular group, medications, brain stimulation, and just in September 2 months ago, there was vagal stimulation for 6 months in a person who'd been in vegetative state for 15 years, who started to respond, and there was demonstration of increased cortical activity. So amantadine I've used, and it can be helpful. Zolpidem has had some pretty dramatic improvement, but it's not as, it's less than 5%, and it's only short-lived. It maybe lasts for an hour, and if there's Parkinsonian features, levodopa should be trialled. Now, in retrieval and acute neurosurgical care, minutes and hours are critical, but rehabilitation is a process that needs to happen early, but the time scale is days, weeks, months and years. The fastest gains after traumatic brain injury occur in the first 6 months. There's talk about the window for neuroplasticity being the first 3 months in traumatic brain injury and stroke. And in traumatic brain injury, improvements definitely continue for up to 2 years, but then they slow down, but they still continue for up to 5 and over 5 years. And some authorities report that recovery and neuroplasticity are a lifelong process and a commitment for the person with traumatic brain injury. Rehabilitation is the process that deals with injury and diseases where there is reduced functioning and limitations to enable maximum and optimal participation. Rehabilitation is a problem-solving approach with comprehensive detailing, assessments to identify and measure the problems and limitations. We develop goals and then apply therapies and strategies to achieve and measure the patient's progress against those set goals. Neurorehabilitation has a skills training and learning paradigm with task-specific training. There's repetition of drills. There's emphasis on practice, learning without making errors, and problem solving in the person's many domains: physical, cognitive, emotional, behaviour, psychosocial and spiritual. The laboratory animal science model, that's the equivalent of rehabilitation, is the enriched and stimulated environment that's been studied in the developmental and also with cerebral lesions. So from Nudo's work, neuroplasticity is enhanced and achieved by the enriched environment. As we can see that there's much more arborization and synaptic and dendritic occurring in the enriched environment as opposed to the isolated. So time alone and sustaining life are not sufficient for neuroplasticity and neural synaptic connections to occur. So you need a stimulating environment, you need the application of the timing of rehabilitation is important so that you can stimulate these neural connections. And when there isn't recovery, we use substitution and compensation strategies, and we model for the care and what the community life is going to be. So comparing outcomes from the literature and between countries is problematic, as there are different systems of rehabilitation and different amounts of rehabilitation. So there's varying levels of access, intensities and duration, different models of care and different funding across the continuum of from acute care through to ambulatory rehab. So this is what the rehabilitation prescription should be. An early start, the appropriate setting, a multidisciplinary team, assessment of the progress, there's goals. When it's an inpatient program, it should be 3 hours a day. The duration should go on for many months and years, and then there should be attention to the community goals and the lifelong experience and lifestyle. So when our patients are not recovering or slow to recover, there should be time out and clinical analysis. The following issues should be considered. Are there any reversible factors affecting recovery? We should review the severity of the injury, the extent of the secondary injury elements that might have contributed as non-traumatic brain injury. Check if there's any spinal or peripheral nerve or plexus injuries. And these patients have been in intensive care. They've had sepsis. They're at risk of critical illness, neuropathy, myopathy, deconditioning and sarcopenia. And we should carefully check for any their visual and visual functioning. And these are the potentially reversible conditions that we need to consider. Hydrocephalus, post-traumatic hypopituitarism, and status seizures, as well as the others listed there. But rehabilitation is also about having difficult conversations in the rehabilitation setting. We have to talk about prognosis, ending rehabilitation, the fact that there's going to be dependency, balancing hope versus reality. But patients and families should be partners in the journey, and really many of them become with their lived-in experience, become experts. So we've got, we need to know about their primary language, their literacy, their culture, and be careful that they're understanding what they're talking to us about, what we're saying to them rather. There's been some very good work in the oncology literature about difficult conversations, and the good thing about that literature is that it's available on the internet, so you can access it and you can use it for these difficult conversations. And they've got special protocols, like one is the SPIKES protocol, which S is for the setting, P is what the patient's perception is, or the family's perception, I is for invitation to talk to them, and K is for knowledge, which is you share the knowledge, and E is for empathy. And the critical thing is to actually get the emotion out and actually have it displayed, and then S is for strategies and the way ahead. And that's been very useful. We train in it, we use actors and role play, and I think it's a very useful thing to do in your work. So, and it's come up again with the DECRA study, you know, is a disabled life worth living? And the quality of life perceptions depend on who and when it's asked. Often people, once they have a disability, still value their life, and obviously there's cultural and ethical and moral issues. 75% of the years lived with disability in the world are linked to health conditions for which rehabilitation is beneficial, and the WHO has called for 2030 to become the year of action and achievement on rehabilitation. So in summary, moderate to severe traumatic brain injury is a chronic condition that requires lifelong management. Delayed and significant recovery can occur in the months and up to 5 years after injury. Diagnostic error is common in disorders of consciousness. Early detection of responsiveness and awareness is important, and rehabilitation works, and we can achieve recovery towards independence after severe traumatic brain injury and disability, and with varying levels of residual difficulties. And quality of life is compatible with significant disability. Thank you.
Thank you, Dr. Peter, for your extensive and authoritative lecture. Thing is that all neurosurgeons are aware that some of our TBI patients remains unconscious for months and months, and then suddenly they wake up in few days' time. I have got 3 patients who had been unconscious on vent for 4 to 5 months, and then unconscious for 7 to 8 months, and then within few days' time, 10 days' time, they suddenly started, became awake, started talking and walking. Well, definitely, neurological sequelae was there, but these 3 cases were in my experience. So I am sure everybody will have a similar cases. Thing is that most of these cases requires patience at the part of neurosurgeon, at the part of the family, and the part of the neuro rehabilitation team, and you have tried to enforce this in your lecture. Thank you very much.
Thank you.
Anything, any question from the floor? Yeah, Dr.
What's the health care like in Australia? I'd like to know from you. Is it like NHS or is it like American Medicare, Medicaid system or NHS?
It's a combination of the NHS and private, so it's more like the UK, Sweden, Scandinavian countries, Northern Europe. So we have a public insurance, a Medicare system that's funded from income tax, and that everyone's got access to rehabilitation in the public system, and then there's a private system as well.
So the rehab. But then,
so what I might say is that this covers the health, but when a person is left with disability, it moves into the disability funding model. So we've got 2. We've got a health funding and disability funding. And people with traumatic brain injury who've got severe disability move from health, and when they're you know, sort of starting to stabilise, they go to a disability funding.
So that's funded by the state?
States and Commonwealth.
States and Commonwealth.
Yeah.
Any private funding? Because this is the big problem in India. The vast majority of people, they do not get rehab at all, neither in private nor in public hospitals. So no one wants to fund, you know, as private. We belong to a small group of private investors, private hospitals.
Okay.
We don't have funds to invest in rehab.
So the average length of stay in inpatient brain injury rehab, traumatic brain injury rehab, is 60 days, and that would be covered in the public system and the private system. But if you were talking about staying in hospital in rehabilitation for a year, that wouldn't be covered in private, but it would be covered in public. So some of these patients stay, you know, it's not unusual for them, for their acute care and their rehabilitation care to take a year or more.
Thank you, sir. So it's already the time.
Do you think there is any future for neural transplant? Stem cell and neural transplant.
Can you just repeat that? I didn't hear it.
Do you think there is any future for neural transplant?
For which transplant?
Neural.
Neural, like, I think there's a future, but I'm not really going to. It's not going to happen in the next 5 or 10 or 20 years, I suspect.
Okay, thank you, Dr. Peter. We can discuss it later on. The next speaker is Dr. Hong Jun Jeon, Management of TBI in the Hybrid Operating Room.
Yeah, almost done. And my last topic is the operational procedure. And before I mention about that topic, I many procedure in our hospital neurovascular disease, like intervention and bypass and clipping and AVM. Also, I charge traumatic patient. This topic is some different. You know, before I conjoin and hybrid the system in traumatic brain. Usually, initial hybrid system is definition is when you face a complex situation, we can use neurosurgical procedure and neurointervention procedure come together at one place without time delay and like that. It's my operating room. It is an angio machine and view box and table, or is a radiolucent, and made by the market, the German company. It is your set box. This is the set box tool. Is Philips Aurora Expert 20. They can use the program or 3D workstation. Yeah, I mean, when I use the Exposity, it's like a situation interoperative confirmation using by angio machine. Yeah, it's a source image transport workstation. We are making our image, and I use the targeting and navigation and reconstruction. I will use that. In this topic purpose, and I prove the safety and effectiveness or a combined approach at the hybrid ward, and combine embolization for neurovascular disease. That case is a high acute state, and Exposity is also can be done confirmation, new region or operation region, and also the guidance system is entry point and targeting system, target region, and navigated by Azure real time. And so during that period, we are 136 TBI that are all severe condition, but 20 cases treated using by this system. Each demographics, they almost a young age, and type of application, HOR, and combined neurointervention, embolization, and coil embolization. The processing is particle and PVA or MBCA glue, and yeah. Another case is just evaluation about the vascular injury, sinus bleeding, or carotid problem. Yeah, also, is explicit confirmation I do usually do check up overall and more than 2 times like that, and explicit guidance in the hematoma aspiration with the navigation system and EVD. I usually do a decompressive craniectomy combined with several techniques. If the patient have a severe condition, I almost don't cutting the temporalis muscle, after subtemporal dissection, and also temporal square muscle is drilled out. And sometimes if the patient have a uncal herniation, I aggressively lobectomy anterior temporal region or non-salvageable tissue as regionectomy under the PR method. And I usually do cutting the dural star shape. I ICP monitor subdural or intraventricular type. High ICP condition, I also directly in the paired, I put in the ventricular catheter in the ventricle. And also, I are cutting the under layer of the scalp. It makes a more elastic expansion, and it also another key point to me. Prosthesis is a chirurgical operation combined with neurointerventional procedure, and let me show my case. 38 male, he is constituted is crushed on his onto the face, severe bony fracture skull base. Actively, he's rapidly his consciousness and rapidly bleeding. Initially, craniotomy was performed, and after that, MBCA grew rapidly. The MMA embolized to the under the foramen spinosum. Is the control like that clear? Another case also is the EDH, 21 patient. We can also cutting the usual craniotomy like a terional, but her patient, her mother never want to large size craniotomy, so 3 hours later, like this image, but she not massive bleeding. Check the angiogram, and the ECA is formation pseudoaneurysm, directing like that. So glucosting, MBCA, and like that. After the mini craniotomy, overall solve out the hematoma, and like that, final image. Another case is during climbing. Here, fall down and had scanty contusion, but severe SH brain swelling, initially semi-comatose mental state. You can see the C-spine CT. Right side is the tubercle is a fracture nearby. Yeah, like that. The traumatic dissection happened to him. And pseudoaneurysm, you can see the 3D bony skull is like that linear line, and also basal skull fracture. Nearby, you can see the pseudoaneurysm source imaging. Yeah, and the guiding system is placed the distal vertebratory left side, and we can. I found some ongoing bleeding like that, very urgent situation. I selected the micro catheter like that, and coiling like that, and post elbow like that. Controllable rapidly. Before I do procedure, I emergency EVD using by the that guidance system. 47 male patient assaulted in a car, and he like this situation, like a spontaneous SH, but here definitely multiple trauma using allowable guides, and he initially semi-comatose mental state on ER. Like that situation, I used the EVD insertion target using my workstation, hybrid room, and like that. Tracing as little time, I can show that at that point. You can see the CT angiogram, and the ongoing bleeding is also happened to him. Yeah. Right side distal vertebral artery is traumatic dissection happened to like that. Ongoing bleeding is also, you can see, I using a stent and coil embolization like that. Post-embolism completely occurred there. Yeah, the processing combined with the neurointervention at the hybrid OR, the system enables check the major vessel injury, dissection, or sinus tearing. And complicated bleeding process very rapidly controlled by the endovascular material, glue or particle or coiling. And sometimes massive epistaxis after trauma, I use the particle sphenopalatine artery, total occlusion, but it never happened to any complication. Traumatic pseudoaneurysm causes ongoing bleeding. It's also a coiling. Yeah, next subtitle is explicit confirmation for new region or open region. It's just a confirmation about the post-op region, but interoperative procedure. 37 male patient fall down, and he has multiple skull fractures like that. He from Uzbekistan, stupor mental state. Massive bleeding is EDH. You can see the fracture, scarf swelling. Yeah, initially I perform decompressive craniectomy for frontal side. Second procedure, explicit confirmation like that. You can see expanded cryptogenic hematoma left frontal side. It's a check. So navigation guidance system, hematoma aspiration do, and also check the brain vascular or surgery evaluation for vascular injury and brain swelling, but any other midline shifting. But I explicit confirmation again. I can show the left side expanded hematoma, traumatic ICH left temporal side. So I'm more aggressively decompressive the that side, and like that. Post-op CT is overall very swelling is controlled, and post-op 3D CT reconstruction image like that, very huge amount of bone loss. After that, I do a titanium cranioplasty using 3D printer system. It is very hard and very protective. To some extent, it's not drilled out because it's very hard. Yeah, after reconstruction of a cranioplasty, pharoplasty, he progressed chronic hydrocephalus, but it could not do shunt to at the original focal point because the titanium mesh. So I do a brief shunt is a PO point. 36 male patient also fall down and initially deep stupor mentally and several times CPR. Large amount of EDH, sensor signs. You can see the major skull fracture or diastatic fracture on sensor side, sensor suture, and like that, very severe condition. At that time, I hesitate because maybe he injured sinus, but like that image. But 3 hours later, his neurological condition was aggressively changed. So initially, I parenchymal type ICP injection, but people change. Without time delay, right away the high withdrawal, like that situation, massively excision the scalp, and you can see the diastatic fracture and press the frontal bone, or often the large amount of bone and excision dural, massive swelling. Yeah, each image during operation, check the CT image and strand, yeah, like that. Intraoperative expressivity confirmation like that, no any other region, but massive swelling, I can check using by confirmation. EVD in also I perform because overall swelling is very severe. So navigation system I use in putting the like that EVD. Expressivity confirmation for new region or OP region, high energy trauma, cryptogenic hematoma expansion can be evaluation with a time delay. If we don't have like this system, we check the CT room and happen to another abnormality, again to OR room. Sometimes it is several repeated, no labeling. Sorry. And also is needed extended craniectomy because another site, yeah, it is possible using by them. And last subtitle is explicit guidance hematoma aspiration as real time. 53 male patients, traffic accidents, large high energy trauma. Frontal lesion is traumatic ICH is with your CPR because of massive swelling and bleeding, like that. Various skull fracture we can see. Yeah. Also is directly massive craniectomy performed and intraoperative guidance, EVD insertion and hematoma aspiration also together. Another case is also EDH and portage, ICH, and confirmation and guidance hematoma aspiration. Like that. This is neurological plea. Yeah. Guidance system is a very higher accuracy system, already known about the GI part, gastrointestinal neurointerventional part. And also, it is minimal invasive, and we can use as a real time, checking by check, easily targeting on the flow map. Yeah, it's my overall conclusion, and per case mortality happened, but low disability is a 6 case, like that. Interestingly, reoperation after using hybrid OR not happened. Yeah, this is my summary. Hybrid OR in TBI, no time consuming. It's a real-time confirmation, and conjoin the interventional procedure, and expedited targeting is also together. So conclusion is system hybrid OR. Another aspect will be safe and effectiveness, I think. Thank you.
Thank you, doctor, for your very good talk on hybrid OT and the cases you have done. In fact, for younger postgraduates, this is a new hybrid CT operation room concept had come, where you will have a operating facility, you will have a CT scan, you can have an MRI, you can have a neurointervention facility. So for anything you don't have to go. If you need a angiogram, you can get it done there. If you want a post-op CT or during operation CT scan, you will have those facilities. It's a real ideal situation. Every neurosurgeon would love to work. Unfortunately, most of us, it's not there. But some centers in this country has developed this in some way or other. So, any question regarding this to the Dr. John? Any question from the floor? I think one thing is there. For extradural middle meningeal meningioma, middle meningeal artery, you did embolized.
Yeah.
Most of us don't require these things. This is a simple procedure everywhere. Why did you do it?
Yeah, and simple case is not necessary because we almost done by doing a surgery, but deep inside and like a deep basal skull fracture, and yeah, it's sometimes a good chance to easily control.
Okay, if, any questions from the floor? No, if it is not there, thank the doctor. I think there is no other paper in this session, so we will close the session. Thank you very much.
Thank you so much. Now, I would request Professor Dr. B.K. Kunwar to present the memento to Dr. Peter Anastasiadis. Professor Dr. B.K. Kunwar to present the memento to Dr. Peter Anastasiadis. Thank you so much, sir. I would request Dr. Peter Anastasiadis to present the memento to our esteemed chairpersons. Professor Dr. B.K. Kunwar. So much, sir. I would request Dr. Peter Anastasiadis to present the memento to our esteemed chairpersons. Professor Dr. S.S. Mishra. And Professor Dr. K.M. Jha. Thank you so much, sir. Now, we'll be moving on to our 6th technical session, where we'll be having some paper presentations, award paper presentations. So for this, I would like to invite Professor Dr. Peter Relly, Dr. Ashish Shuero, and Professor Dr. B.S. Das on the dais. Dr. Ishi and Professor Dr. B.S. Das on the dais. I would request Dr. Nam Kyu Yu, Dr. Hong Ju Jo, and Dr. K.M. Jha to take the front seat to judge the award paper presentations.
The time is 10 minutes. And at the end of 8 minutes, we'll give a sound like this. Right. So that means 2 minutes left. When the 2 minutes, last 10 minutes are over, I think you should stop by that time. The first speaker, Arun Kumar, study of cranioplasty in decompressive craniotomy patients.
Thank you, sir. Everyone knows the value of quality of life, but how to improve the quality of life in a patient of severe trauma? Decompressive craniotomy is a life-saving operation for severe brain edema with impending brain herniation due to severe head injury and malignant middle cerebral artery infarction. The Trephin syndrome is characterized by neurological symptoms such as headache, seizure, focal deficit, and cognitive and behavioral changes. Evidence in recent literature, cranioplasty may also accelerate and improve neurological recovery apart from cosmetic value. The main argument for early restoration of skull defect is avoidance of post-decompressive hydrocephalus and or development of the Trephin syndrome. It has been postulated that prolonged persistence of large skull defects exposes the patient's brain to increase the atmospheric pressure and mechanical external pressure, which consequently causes regional hemodynamic and metabolic impairments. Better clinical outcome thought to be due to reduction in tissue edema, improved collateral circulation, and improvement in oxygenation and energy metabolism in injured tissue. There is no defined time frame to do cranioplasty after decompressive craniotomy. The prerequisites are there should be healthy scalp wound with no local systemic or cranial infections, no residual brain swelling, and no hydrocephalus. The optimal timing for performing cranioplasty seems to play an important role not only in avoiding procedure-associated complications, but also in the neurological outcome of these patients. Now coming to the review of literature, what literature says and when to do a cranioplasty, and if we are doing early cranioplasty, what will be the advantage, and if late, what will be the disadvantage. The two literature shows that very early cranioplasty in less than 2 weeks lower the overall cost of care. And one literature shows better in patients with early cranioplasty, like if less than 86 days or more than 85 days. And the third one, Severa et al. In 2010 discovers that in Glasgow outcome scale, there is improvement in 67% and in 67% of the patient. And one more literature, Liang et al. Shows that early outcome improved in neurological function in 78 to 3% of the patient in long-term outcome. There are 3 series showing the early cranioplasty provides a better functional outcome. Bender et al. Found that a patient with shorter delays to cranioplasty had a better functional outcome than patients with longer delay. Severo et al. Concluded in their cohort that early cranioplasty could improve the neurological outcome. Similarly, Liang et al. Suggested that cranioplasty could be safe and may improve the patient neurological function. They found that most of the patient regained consciousness and improved their neurological performance after cranioplasty. Now coming to the aims of this literature or my topic, this study was done with the aim to assess clinical outcomes after cranioplasty in decompressive craniotomy patient. The objectives were impact of timing on cranioplasty, the functional outcomes in early cranioplasty. Now, material and methods, a study on patients who underwent cranioplasty after decompressive craniotomy for severe traumatic brain injury and malignant middle cerebral artery infarction at Apollo Hospital, Bhubaneswar, Odisha from period of 1st March 2016 to 31st March 2017. 30 patients were recruited for this study. Research Ethics Board approval was obtained for this study. All male and female patients of 80 years and 70 years included in this study. Unilateral decompressive craniotomy due to severe head injury included. Unilateral decompressive craniotomy due to malignant middle cerebral artery infarction is also included in this study. Now this picture showing the Trephin syndrome in 2 patients. Now exclusion criteria, patients below 18 years and above 17 years are excluded. Craniotomy for tumor and cranioplasty in same sitting. Craniectomy for infection followed by cranioplasty. Craniectomy with previous head injury and stroke were excluded from this study. Patients with bilateral craniectomy are also excluded from this study. Cranioplasty by other than autologous method were also excluded. Now, during admission for cranioplasty, following outcome scale were used to assess Glasgow outcome scale extended, modified Rankin scale, mini mental state examination. For clinical outcome, assessment scales were repeated post-cranioplasty at 4 weeks, 12 weeks, and 24 weeks. Data were analyzed using SPSS software version 2. The following variables are also assessed using logistic regression: name, age, preoperative goals, indication for surgery, location of craniectomy, time from craniectomy to cranioplasty, post-operative goals, ranking scale, and mini-mental state examination. Post-operative complication, length of stay in hospital. P-value less than 0.05 will be significant. All patients were evaluated before cranioplasty as per operative protocol for cranioplasty. The prerequisite for cranioplasty, as said by earlier. Now, this is the short operative note. Cranioplasty was done under general anesthesia in supine position. And scalp brain was usually removed on post-operative day 2. Scalp and abdominal stitches were removed after 10 days. You usually discharge the patient on 3rd post-operative day. First follow-up was done after 1st week. Then patients are asked to come follow-up 1 month, 3 months, and 6 months. An observation chart was prepared like this. Pre-op and post-op comparison was made. This is a master chart showing the all variables. From the total of 30 patients, 22 were male and 8 were female. Patients were aged from 18 to 70 years. Out of 30, 20 were operated for severe head injury and 6 were operated for malignant cerebral artery infection. In 20 patients, cranioplasty was done at 6 weeks, 4 underweight at 4 weeks, and rest underweight cranioplasty at 8 weeks. We could not assess mini-mental state examination in 4 patients due to low Glasgow coma scale. And this is the demography analysis. This is a pie chart showing the male to female ratio in a study. A column chart showing the educational level of patients. A bar chart showing the distribution of cranioplasty patient. MCA infarction is 6 patients and head injury, severe head injury 24 patients. And results, the median value of GOS at pre-cranioplasty 4 weeks, 12 weeks, and 24 weeks post-cranioplasty was 4, 5, 6, 7. The median value of modified Rankin scale pre-cranioplasty 4 weeks and 12 weeks and 24 weeks was 5, 5, 4, 3. The median value of mini-mental state examination pre-cranioplasty 4 weeks, 12 weeks, and 24 weeks for post-cranioplasty. And that was 22, 25, 25.5 respectively. It was a statistically significant difference in the median value of mini-mental state examination pre-cranioplasty and 4 weeks post-cranioplasty. At 24 weeks post-cranioplasty, median value of MMSC further improved. The median value of MMSC at 4 weeks post-cranioplasty and 24 weeks post-cranioplasty was also significantly different. Now chart showing the GOS score at different weeks in linear relation. A line chart showing the MRS score at different weeks. Pre-cranioplasty 4 weeks, 12 weeks, and 24 weeks. Line chart showing MMS score at different weeks. Now discussion, it has been documented that cranioplasties were performed by the Incas many centuries ago. Cranioplasty is considered as one of the earliest neurosurgical procedures along with cranial trephination. The main reason for performing a cranioplasty nowadays is previous performance of deconstructive craniectomy. Historically, cranioplasty has been recommended at least 3 months after initial craniectomy. Recent reports indicate that in selected otherwise healthy patients, early cranioplasty after 6 to 8 weeks may aid recovery. And moreover, early cranioplasty may allow easier discrimination of various tissue layers when a scalp flap is reflected. In our study, there is significant improvement in neurological status in early cranioplasty with reference to GOS, MRS, and MMSE. The selection of our patient had a wide age range, different education level, different indication for decompressive craniectomy, trauma versus non-trauma, time of cranioplasty, letality of decompressive craniectomy, and choice of cranioplasty material may have influence on the clinical outcome of this patient. Conclusions, cranioplasty is a relatively simple procedure with minimal complication. Early cranioplasty contributes to better neurological outcome and improve all our prognosis in selected patient. It also reduces the length of a stay and thus all the overall cost of the care. Thank you.
It's open for questions.
Thank you. Could you just explain to me again how the time was chosen why were some patients operated on early and some late? Why was the time of cranioplasty? How was that chosen? You've compared two groups. You compared the ones that had cranioplasty before 4 weeks and those that had it later.
No, we operated in 4 weeks.
Yep.
4 weeks, sir.
And so what were you comparing the good results against?
Pre-cranioplasty, there was a score difference in pre-cranioplasty and post-cranioplasty. So this was my observation, sir.
Right. So how were you able to say that the cranioplasty made a difference?
I utilized the Glasgow Outcome Standard and the mini-mental state examination pre-cranioplasty and compared with the post-cranioplasty mini-mental score examination.
So there is no control group. So how do you say that the cranioplasty made a difference and that they were not just recovering from the head injury?
Sir, cranioplasty improves the regional homeostasis.
Asking how you don't have a control, so how do you say that cranioplasty has made a difference?
Because pre-cranioplasty score was different and post-cranioplasty score was different. So this is observational study, sir. And after doing the cranioplasty, the score has drastically improved. So I can say cranioplasty has improved the outcome of quality of life of these patients.
You don't think they were just recovering from their injury?
Pardon?
Do you think they were just undergoing the normal recovery from their injury or their stroke?
I didn't get it.
When you do a cranioplasty,
yeah,
don't you expect that the recovery of the injury must be continuing?
Yeah, must be continuing,
So
but after doing cranioplasty, it will become faster recovery. Recovery will be faster.
One comment that regarding this very good study, but the thing is that what sir is saying, you should have got CBF done. What we are doing, if we are planning for a cranioplasty, we are doing CBF and post-cranioplasty. CBF and change in CBF, you can show that there is a definite increase in the CBF. We have
Yes,
got
sir.
about
There is definite relation between cerebral perfusion pressure in CT scan, pre-cranioplasty and post-cranioplasty.
that you have to document. Like
Thank
it's
you.
there.
Yes, correct. You are correct.
And now that's why, because there is a gross difference between CBF after decompressive craniotomy and your cranioplasty. What we have started doing a 4-quadrant cranoplasty. We are not removing the bone at all. We are just taking during the duroplasty, cutting the bone and putting it back. So that CBF remains, difference is only hardly 8 to 10 millimeter.
Dr. Srivastava will go into
4-quadrant cranoplasty.
Yeah, thank you. Thank you very much. We'll discuss later on. Thank you. Thank you very much. We call next person, Avijit, study of intracranial pressure monitoring after primary decompressive craniotomy. Study of intracranial pressure monitoring after primary decompressive craniotomy.
Good evening, everyone. This topic has been discussed since morning by many people. Study of intracranial pressure after decompressive craniectomy for traumatic brain injury at tertiary care center at Odisha. Trauma is a major cause of mortality worldwide. According to the predictions, neurotrauma will account to an increasing number of deaths worldwide by 2020. The TBI definition we all know about is the injury to the head arising from blunt or penetrating trauma or from acceleration or deceleration injuries causing decreased level of consciousness, amnesia, objective neurological, neuropsychological abnormalities, skull fractures, diagnosed intracranial lesions or head injury listed as a cause of death in the death certificates. The vicious cycle of mechanical compression, edema, hypoxia, ischemia leads to the rapidly deteriorating secondary injuries which require urgent surgical interventions. Intracranial hypertension is the major cause of secondary brain injury, leading to morbidity and death. Thus, the treatment protocols are guided to control the intracranial pressure in the patients with TBI. The purpose of this study is to evaluate the correlation of post-operative ICP monitoring placed during the early decompressive craniectomy with mortality and for guiding the therapy in patients who underwent the early decompressive craniectomy for severe TBI with mass effects. The aim was to study the intracranial pressure after decompressive craniectomy in cases of TBI. Materials and methods. The study setting was OPD emergency indoor departments of Apollo Hospital, Bhubaneswar. Study duration was from April 2017 to August 2017. Study design was a hospital-based observational analytical study. All patients with traumatic brain injuries and of traumatic mass lesions who were undergoing decompressive craniectomy in the adult age group were included. Patients under 18 years and above 65 years were excluded. Severe extracranial lesions such as cardiovascular, pulmonary or abdominal injuries were excluded. Patients with systemic comorbidities like IHD, CKD, uncontrolled diabetes were also excluded. Admissions with diagnosis of brain death were not included. Measurement of outcome of interest. The outcome was measured by Glasgow Outcome Scale extended at the discharge of the patient from hospital at an interval of 2 weeks, 1 month and 2 months after the surgery. How did we measure the ICP? The intracranial pressure was measured at intraventricular and subdural spaces. The method used for intracranial pressure measurement was the intraventricular catheter, subdural catheter, connected to the transducer, kept at the level of the external auditory meatus, connecting to monitor, measuring the ICP and showing the waveform. Length of the tube from the intraventricular catheter to the transducer was 1 meter, and same diameter of the tube was used in all the patients. Here I would like to remind the paper by Dr. Joseph Matthew from CMC Vellore about the measuring the ICP in the resource constraint settings. This is how we did it. We put an intraventricular catheter which was connected to the pressure transducer, which was transmitting to the waveform to the electronic monitor, and also to the CVP line, which was having a continuous water column to measure the ICP. This is how it was being shown on the screen. Now coming to the results. The frequency for female was 14 patients out of 34. 14 patients were female and 20 were male. Age-wise distribution, most of the patients were more than 50 years of age. Mechanism of injury, fall was recorded in 5 patients, while 29 patients out of 34 were having an RTA as a mechanism of injury. GCS before decompressive craniectomy, mean was 5.53, standard deviation 1.331, minimum was 3 and maximum 8. Pupil response-wise distribution, equal and non-reacting was recorded in 15 patients, equal reacting in 16, unequal non-reacting in 3 patients. Decompression, bifrontal decompression was done in 2 patients, while left in 21 patients, right was done in 11 patients. The type of the lesions which were encountered during the study, most of the patients were having SDH and SDH plus contusions as the most common reason for doing the decompressive craniectomies. The mean ICP was recorded as 22.0662. Standard deviation was 7.169. Minimum ICP that was recorded was 12.75. This is and maximum was up to 42.5. 2 ICP groups were made considering the 20 mm of Hg as a cutoff. Abnormal was considered in 19 patients and normal was considered in 15 patients, taking 20 mm of Hg as a cutoff. Now coming to outcome, at 2 weeks of duration after the decompressive craniectomy, 4 patients were dead, counting around 11.76%. Maximum outcome recorded was 7, range was 1 to 7. Outcome 7 was recorded in 2 patients, 5.8% of total. Outcome 6 was recorded in 13 patients, was 38.23, and maximum outcome was from range 2 to 5, which was in 15 patients, 44.11%. Outcome at 2 months, no additional mortality was recorded in these 34 patients at 2 months of duration. Maximum outcome was 6 patients. Outcome 7 was recorded in 8 patients, that was 23.53%. Outcome 6 was in 6 patients, 17.64%, while 2 to 5 was 10%, which has drastically reduced in the 2 months duration. Now coming to correlation, after correlating the ICP, the level of ICP and the outcome, we have found a very strong correlation between the level of the ICP post decompressive craniectomy and the outcome at 2 weeks and also at the 2 months duration. Discussion, after the most recent publication by Chestnut, as was mentioned by Sir. 3 consensus conferences in 2012, 14 and 15 were held, resulting in decision to reassign ICP monitoring a key role in the management of severe TBI. The Milan Consensus Conference in 2014 about clinical applications of intracranial pressure monitoring traumatic brain injury defines the role of ICP monitoring under 4 conditions: following diffuse brain injury, following cerebral contusions, following secondary decompressive cranectomy, and following evacuation of intracranial traumatic hematomas. According to this consensus, the recommendations for ICP monitoring after secondary decompressive cranectomy include the statement ICP monitoring is generally recommended following a secondary decompressive cranectomy in order to assess the effectiveness of decompressive cranectomy in terms of ICP control and guide the further therapy. Still, very little is known about the role of ICP monitoring after primary decompressive cranectomy. This was for secondary. Very little is known about the primary decompressive cranectomy. So our main results can be summarized as the intracranial hypertension was frequently observed after the primary decompressive cranectomy. Unfavorable neurological outcome was associated with greater mean intracranial pressure. And after primary decompressive cranectomy, ICP monitoring augmented and improved the neuro ICU care. Episodes of elevated ICP and low CPP have been historically been associated with unfavorable neurological outcomes in TBI. Our study supports this previous observation and suggests that a similar relationship also presents in TBI patients after primary decompressive cranectomy. Limitations of this study were the number of the patient was very less, only 34 patients are included. A retrospective analysis of prospectively collected data. We need a controlled trial to confirm our findings. Now, we are not following the previously described sensor method for determining the ICP values for this study. Chances of error are still there while recording the data. This is still an ongoing study and the paper only gives the interim results. Final outcome of the study is still awaited. The conclusions are the intracranial hypertension occurs frequently after the primary decompressive cranectomy and is associated with unfavorable neurological outcome. Our results suggest that the ICP monitoring is clinically useful in guiding the therapy after primary decompressive cranectomy. Thank you.
Is open for questions, short questions.
Thank you for great presentation. So, you measure the ICP after primary decompressive craniectomy.
Yes, sir.
And if you see the abnormal ICP, I mean ICP hypertension after primary decompressive, do you have an option to decrease ICP? So,
yes,
for
sir.
example, internal decompression.
So the ventilatory modifications can be done. Secondly, we can put an EVD, extraventricular drainage, in the opposite side to drain the CSF if the ICP is still not being controlled by the decompressive cranectomy. Or in very few patients, we can also go for the, if done on one side, we can go for the other side decompressive cranectomy. That can be an option in some patients.
In this study, so you did that.
So we have not done any bilateral. Only bifrontal we were included 2 patients, but bilateral we have not done as a part of the management as intracranial hypertension. So, plus this was not a part of the study. We were only correlating the ICP with the outcome in these patients. So.
Well, did your patients getting mannitol or hypertonic saline or Lasix?
Yes, sir.
Lasix simultaneously?
Yes, sir. Yes, sir.
So how do you explain the effect of the decompression cranectomy alone, without medical treatment?
So the hypertonic saline, mannitol, and Lasix were also started in all of the patients as the part of the initial management of the trauma, sir, for considering the mass effect, and it was being continued for all of the patients.
Okay.
Thank you very much.
Thank you, sir.
Next person is Dr. Balwant Singh. Observational study of minimally invasive discectomy in lumbar disc prolapse.
Respected honored guest, good evening everybody. We'll be discussing about minimal invasive discectomy observational study. We'll also compare the minimal invasive discectomy with the conventional one. Now, lumbar disc herniation is the displacement of disc material beyond the intervertebral disc base, causing low back or leg pain. Conventional surgeries included fenestration discectomy, laminectomy discectomy, and minimally invasive surgeries include percutaneous discectomy, vaporization, ozone intervention, radiofrequency ablation, and microsurgical discectomy. Since the introduction of lumbar microdiscectomy in 1970, studies have been attempting to compare the effectiveness of this method with the standard one. But in recent years, with the development of modern science and technology, it becomes more and more popular to apply minimal invasive surgery for treating LDH. In 1977, Yesargil and Casper independently introduced the technique of microdiscectomy for treating lumbar disc herniation. This technique offers better visual control of operative field, less traumatic, smaller incisions, and compared to standard conventional discectomy. A majority of randomized controlled trials have been demonstrated better efficacy of minimal invasive surgery in treating LDS than conventional surgery, but inconsistent conclusions were also reported. Various studies have been done, like Rigoso et al. Reported that patients treated by minimal invasive surgery had higher incidence of post-operative complications than those by conventional surgery. Then in China, Z et al. Reported some post-operative excellent rates between minimal invasive and conventional surgery. Mao et al. Reported that there was no difference in the indices of pain, function, and treatment satisfaction between minimal invasive and conventional. So therefore, this observation study is designed to compare the relative effectiveness of minimal invasive discectomy with conventional one for treating lumbar disc herniation. Moreover, no such study has been carried out in local population. Our aim is to compare the relative effectiveness of microdiscectomy with conventional discectomy. Objectives will evaluate demographic profile and relative effectiveness on following parameters: surgery time, incision length, blood loss, hospital stay, improvement in symptoms using VAS and ODI score, return to work, recurrence rates, persistence of symptoms, and complications. Now, material methods. The study included patients visiting our OPD emergency in Apollo Hospital, Bhubaneswar. For a duration of 2 years, 220 patients were studied. Inclusion criteria: patients with lumbar disc herniations, adult, aging 18 to 17 years. Those patients who were refractory to conservative management were also included. And exclusion criteria was lumbar PIVD resulting after trauma over lower back, neoplastic lesions over lower back, any type of infection over lower back, multiple level PIVD, spinal deformities, recurrent disc listhesis. So study protocol was formed, demographic profile, age, gender, duration of symptoms, hospital stay, and parameters were as described. Patients were assessed pre and post operatively at 6 weeks, 6 months, and 1 year duration. Clinical examination entailed the straight leg raising test for knee and ankle jerk, sensory loss, and muscle charting. A radiological examination included radiography, MRIs, and electrophysiological studies. Neurological improvement was assessed using muscle charting and electromyography. Low back pain and functional outcome were assessed using ODI questionnaire. Outcome was considered satisfactory if radicular symptoms had ceased, tension signs and become negative, and the patient returned to previous occupation or normal activities. These images show both minimally invasive and the conventional discectomy. Here we use a small port. Sheets I use with around 2 to 3 centimeter incision, and whereas in conventional 4 to 5 centimeter incision is generally required. Results. Comparison of demographic profile in 220 and 220 patients, we found out that number of males were more who underwent discectomy, both microscopic and conventional. Then comparison of surgical indicators: anesthesia time was equal in both cases, but surgery time was less in microscopic discectomy. Incision length was comparatively less, and blood loss was less. Now, comparison of clinical parameters. Duration of symptoms were almost similar in both the patients. VAS score was significantly improved in microscopic discectomy. Hospital stay was less, and patient returned to work earlier in minimally invasive surgery discectomy. Now, improvement in Oswestry score. The ODI score pre and post operative were significantly different just after operation. In pre-op, around 110 patients were with minimal oswestry score, and 30%, that is moderate oswestry score, 43 patients were there. But at follow-up, at 6 weeks, 6 months and 1 year, the oswestry score differences were not seen. So the demographic distribution was found to be different in both. Male-female ratio was 1.85:1. Anesthesia time was equal in both the groups, whereas surgery time, incision length, blood loss were significantly reduced in minimally invasive discectomy. Duration of symptoms are almost same in both groups. VAS score and ODI scores were significantly improved. But hospital stay was significantly less in minimally invasive technique as compared to conventional one. Patient undergoing minimally invasive procedure could return to work earlier. Improvement in ODI scores were significantly improved post-operatively in minimally invasive procedures, as these patients have less tissue damage and the epidural venous systems are not disturbed during minimally invasive procedure. This helps to prevent venous stasis and chronic nerve root edema. But at 6 weeks, 6 months and 1 year follow-up, ODI scores were same in both the groups. Our discussion. Microdiscectomy has better approach to canal, compressed nerve root and the herniated disc. It is less traumatizing to the paravertebral muscles, results in less fibrosis inside the canal, less morbidity, shorter hospital stay, early return to work, and greater overall patient satisfaction. Although the clinical results are almost similar in both procedures, but considering the efficacy of procedure in terms of incision length, surgery time,
using data from 5
blood loss, tissue damage, hospital stay, return to work, the minimally invasive procedure is better as compared to conventional discectomy. A conclusion, a good control of indication is the basis, accurate positioning is the prerequisite, protecting the nerve root is key, complete discectomy is must, full decompression is the fundamental, and all the factors work together to make minimally invasive surgery perfect. The significance of minimally invasive surgery under the microscope is reducing blood loss, complications, and iatrogenic injury, shorter hospital stay, lower medical cost, and promoting faster recovery, so as to get the same, even better efficacy compared with traditional surgery. Thank you.
Thank you. It's questions.
It's nice. How can we randomize? How can we select? One for micro, one for conventional. How can is it age-wise selection?
No, sir. My study is an observational study. I am studying basically of patient undergoing minimally invasive procedures, and I am comparing it with those who have patients in those who have already undergone conventional one. So I am studying only about minimally invasive, and I am comparing it with the conventional ones, who have already undergone.
This is only bias. Otherwise,
yes, sir.
Results is quite vary according to age, older age group vary, whatever surgery
Yes,
do,
yes, sir.
comorbid condition, lots of factors is there. Only this factor you cannot decide these things. Okay, anyway, thank you.
I understand the groups were operated by different surgeons. That's how you chose who had microdiscectomy, who had who was in the other group.
Not by the same surgeon.
No, sir.
Two different surgeons.
Yes, sir.
That's how they were separated,
yes,
and the groups were matched in terms of their functional status
yes,
beforehand.
Sir. In terms of the following surgical parameters based on the operating time, incision length, then blood loss, tissue damage, everything.
Right. Surgical complications, did you have, I didn't recall that you mentioned any surgical complications. Were there no surgical complications in either group?
No, sir, but functional recovery was both, functional recovery was initially better in minimally invasive groups. But for a,
any operative complications?
No, so operative complications.
No operative complications in either group.
Yes.
Thank you. Our next gentleman is Deepak Vanchal, comparing posterior fossa decompression with or without duroplasty in surgical management of adult cherry 1 malformations.
Respected Chairperson, today my topic is comparison of posterior fossa decompression with or without duroplasty in surgical management of adult cherry 1 malformation. So introduction, cherry 1 malformation refers to the downward displacement of the cerebral tonsil through the foramen magnum into the upper part of this spinal canal. So various of cherry malformation are cherry 1, 2, 3, 4 and cherry 0 and cherry 1.5. Among the subtypes of cherry malformation, so cherry malformation type 1 is defined by the degree of cerebral tonsil extension, so below the Bayesian opposition line on sagittal and coronal lamella. So CM1 is defined as cerebral tonsil herniation, so more than 5 mm, so in patient more than 5 mm, and it is also more than 6 mm in patient older than 15 years. Despite the fact that many surgical modalities of cherry malformation have been used, controversy still exists. Two main types of surgical modalities have been advocated for treatment of CM1. So one type is posterior fossa decompression with or without duroplasty, and other one is reduction of the syrinx cavity using different of shunt procedures. So posterior fossa decompression still remains the primary surgical technique for the treatment of cherry malformation 1 because the shunt technique produces a risk of iatrogenic spinal cord injury. Extensive work has been performed concerning the duroplasty or only decompression. However, so whether duroplasty is performed during posterior decompression remains still controversial. A retrospective study of 28 consecutive patients and their procedure from 2015 to 2017 was performed in the hospital in our department, and included whatever the age above 18 years and cherry malformation with and without syringomalia and absence of other CV junction malformation, tumor, infection, trauma. We excluded patients with other types of cherry malformation and patients with other major medical illness. So all the patients underwent surgeries and specific surgical procedure was chosen by each surgeon on the basis of the training and personal preference, that is with durotomy and without duroplasty. And the medical record and radiographic characteristic including MRI and CT was reviewed and compared. And initial MRI with contrast was performed before and on arrival in the Neuro department. And science was getting into grade 1, grade 2 and grade 3. So grade 1 was the tonsil between some more than 5 mm, and grade 2 or tonsil is a C1 arch, and grade 3 or tonsil descended over below the C1 arch. And location of series was classified as non, cervical and beyond cervical. And surgical procedure was we had used durotomy and otherwise without durotomy. The follow-up outcome, the patient was followed up at 1 month, 6 months and a 1 year follow-up. And the results were qualified as excellent, good and poor result. The excellent was that there occurred improvement of the neurology deficit, and good was suggestion of the progression of neurology deficit, and poor results were so there was no deterioration. An MRI study was performed at 6-month interval. My first index case was a 35-year male present with neck pain for 3 years, weakness of left upper limb for 6 months, and numbness of left upper limb for 6 months. There is no history of respiratory difficulty, facial weakness. On examination, the power was shoulder joint 2/5, elbow joint 3/5, and wrist joint 4/5. And sensory, they decreased pain touch temperature by 70% on left side and preservation of fine touch position vibration by C5 to D1 dermatome. This is a preoperative MRI, and this is so the Bayesian opposition distance is 26.3 mm, and tonsil herniation was 7 mm in this, and we had undergone duroplasty procedure in this. And this is the preoperative MRI and post-operative MRI, which shows the Bayesian opposition distance, which was 26.3 mm in the pre-op MRI, which has improved to 35 mm in the post-op MRI. And the tonsil herniation, which was 10 mm in the pre-op MRI, has improved to 4 mm in the post-op MRI. And the complication, so CS leak was seen on the second post-op day at 1 month, so no significant improvement, and at 6 months, decreased pain and weakness of both hands. In this case too, so 27-year male present with pinprick sensation of the chest wall, back and both of upper limb for 5 months, weakness of right upper limb followed by left upper limb for 4 months, and pain of the back for next 3 months. And the patient was, and the power of the joint was 4/5 across all joints and across all movement, and sensory there was decreased pain, touch and temperature by 80% on left side from C2 to T12 dermatome, and the neurological was grade 2. This was the preoperative MRI. We saw the Bayesian opposition distance was 22.4 mm, and tonsillar herniation was 8 mm. And this person has undergone only posterior fossa decompression without duroplasty. And the complication follow-up, at 1 month interval, pain decrease in intensity at 6 months, so the patient completely painless. This is preoperative MRI, post-operative the basin operation distance is 22.4 mm, is now decreased to 31.2 mm, and tonsillar herniation is 8 mm, now decreased to 4 mm. The result and discussion, so number of patients were treated at 28, so there are 11 male and 17 females, and the decompression was done in 13% and neuroplasty was done in 15%. And the mean age was 30.18 years, and the mean hospital stay was 20.3 days. This theory malformation, one patient present with different system, and the main symptom was sensory loss, which was seen in 71.4%, and tingling and numbness was seen in 64.2%, muscle weakness was seen in 64.2%, and neck pain was seen in 39.2%. These were the some main preoperative symptoms, and which comprised of headache, neck pain, sensory loss, and numbness and tingling. These are the main symptoms, and so all the patients underwent MRI examination and several tonsil descent, and location of the syringes were recorded. No significant difference was found between the groups in the descent and location of syringes. This is radiography, and it is graded at grade 1, 2, 3. So grade 1 is observed in 6%, grade 2 that is in 5%, and grade 3 in 17%. And the location of cervix and location of syrinx was that it is none in 2%, cervical that is at the level of cervix, at the level of cervical it is 7%. The most common complications were wound infection, which is in 3.57%, aseptic meningitis in 14.28%, and CSF fistula in 3.57%. And in summary, and the main summary of complications are reoperation, so wound infection, aseptic meningitis, CSF fistula, subcutaneous hydrops, and other complications. These complications are mainly seen in the patient undergoing neuroplasty. In this patient, in this study, so the patient clinical outcomes were recorded at 2 times. So one is short term and one is long term. So currently, so no general consensus exists for incorporating neuroplasty in the surgical treatment of cerebral malformation. Some authors have advocated that so only neurotomy is sufficiently effective, whereas others have suggested adding neuroplasty. Some authors have concluded that the surgical outcomes between the neurotomy and the without neuroplasty groups are not significantly different, so, but the complication rate is higher than in the without neurotomy group. This difference in complication may be related to the fact that so neuroplasty has more steps than only neurotomy, and it requires opening of the dura and suturing of the dura with different types of materials. This destroys the integrity of the original dura and increases the risk of CSF-related complications. The result of studies are consistent with this conclusion. That is, patient going only decompression, the clinical improvement seen is 69.2%, and overall complication rate is seen at 40.66% in the case of patient undergoing neuroplasty. The conclusion, an increase in the posterior volume, and specifically an increase in the cisterna magnum volume, was associated with a greater likelihood of clinical improvement in headache and tonsillar descent, and also associated with a greater likelihood of improvement in syrinx and cervical linking. The neuroplasty leads to more reliable reduction in the volume of concomitant hydromelia compared to the only decompression group. So in our study, the clinical outcome of without neuroplasty is nearly identical to from with neuroplasty.
It's open for questions. Any questions? There is
you have neuroplasty done with the autologous graft or different material you have used? What material is used for neuroplasty?
Neuroplasty we have is G-patch or the spericranium, G-patch or the fascia lata.
Different material.
Different
materials.
Now, during the surgery, did you have any time the CSF coming out when you just opened it and left it?
Just outwashing of the arachnoid membrane is done. No CSF leaks out.
Thank you. Yes. Hey, come on.
How do you compare with your study?
So literature shows so there is high complication rate. So there is high complication rate in case of neuroplasty. But the clinical outcome is same in both the groups.
Thank you very much. I thank the chairpersons and thank me also for her participation.
Thank you so much, sir. We'll be having our inaugural ceremony at 7 o'clock. So till now, you all can sit back, relax, and enjoy your time.
Relax.
Thank you.